Welcome to our global expert talk on lessons from 2 decades of US telecritical care, what to adopt, what to avoid, and why. Critical care once relied almost entirely on who was physically present at the bedside, often leading to delays, variability in decisions, and uneven access to expertise. Telecritical care has changed that reality by extending continuous monitoring, specialist input, and timely escalation beyond the ICU walls. This panel will explore how tele-ICU has reshaped clinical decision making, improved patient safety and outcomes, bridged gaps in resource limited settings, and where its greatest value lies for the future of critical care. To discuss with us, we have with us Dr. Saurabh Chandra, Chief Telehealth Officer at University of Mississippi Medical Center, United States. Welcome, Dr. Saurabh.
Thank you, Dr. Khurana, for the invitation. It's indeed an honor and a privilege to be here today.
Sir, so my first question to you would be, before telecritical care, how were ICU patients monitored and managed, and what were the key limitations of the pre-tele era?
So, and before the telecritical care era, and those who are not familiar with the tele-ICU, let me just explain for your audience that tele-ICU utilizes remote technology, audio visual technology, as well as data to provide, supplement, augment care at the bedside. And this has been there for almost 2 decades now and has really evolved over this period of time. And before tele-ICU was introduced, and even today for many ICUs that lack tele-ICU, it's the usual way of doing business, meaning the monitoring, instead of a centralized dashboard receiving in the tele-ICU information from multiple ICUs across board, you have bedside monitoring for physiological monitoring that displays the data from the patient. But then who is seeing that? You have to be available, and if something is happening, the nurse actually is the first responders. They go when they are rounding. So it's not continuous monitoring of data or even physiological or vital signs. And that is how things were done. Now you have tele-ICU where they have centralized dashboards. Data is continuously flowing in, and there's someone available to provide that monitoring and responding to alerts. And because the nurses, before tele-ICU, the bedside nurse have, every time there is an alert, they have to rush whatever they're doing to see if this is a real alarm or false alarm. So it adds to the fatigue for the bedside nurses. But that is how things were done. The monitoring by the bedside nurses, they are escalating care to the physicians that are not available readily, especially during after hours. So that's how things were done before tele-ICU, and more dependent on human vigilance, rather, I would say, than machine vigilance.
Right. So I think it has augmented the way we take care of our patients in the ICU. So what, according to you, which telecritical care tool have proven to be the most useful in routine ICU practice, and why have they stood the test of time?
Yes. So the second answer, I'll start with the second question first. There have been many different tools that have been implemented over time, tested. Studies have been done both at individual hospital level, but also across multiple ICUs, multiple trial sites. And so there's a lot of published data over the last 2 decades that have been captured. And what have stood the test of time are the tools that have provided and have evidence has found to support that they provide value in taking care of patients. So that is the test. Like, hey, are you providing value? Are you actually And when I think about value, I think about how is it supporting the bedside providers, both nurses and physicians, but also how is it improving clinical outcomes and in terms of ICU, length of stay, mortality, ventilator stay, infections. So the tools that have improved these outcomes are there to stay, and the ones that did not need to provide that kind of outcome, they have kind of are not at the front right now. So some of the tools that we have found is that are really beneficial is the audio video technology anyways, where it allows us to go in and provide early decision making, consult, evaluate the patients, support the bedside teams when they don't have enough resources, enough physicians, critical care trained physicians at the bedside. So audio video technology is the backbone. You press a button, you are there without delay, available to support the bedside team. And then one other thing is that, as I mentioned before, when the tele-ICU is not there, the monitoring is fragmented. It's not continuous. It's dependent upon the nurses going to the patient's bedside, alerts going to them, they come to the bedside and then respond to them, escalate care. So the other thing that has really made a difference is continuous physiologic monitoring that is coming and flowing into our centralized hub, which is monitored by nurses 24/7, so they can respond, they can use the audio video technology, make sure that patient is safe, and then escalate care. And that has shown that allows, both of these things allows us to make care more proactive rather than reactive. So instead of providing care when something really happens, it allows us to be more proactive, allows the trends to be monitored, and then make early decision for the benefit of the patient. So that is another thing that has really stood the test of time. And the other very important thing, the one that comes to my mind in the setting of ICU, is protocol-driven care. It allows us to actually standardize care. So at one time, we are monitoring multiple ICUs within a health system, but because many of the ICUs, even within the hospital or across multiple hospitals, have variations in the protocols, and some of them may not be having protocols that they are readily enforcing. So tele-ICU can have standardized protocols. Of course, they're tailored to the resources that are available at the bedside, but then ICU is such a protocolized driven care that it really enables us to standardize care across multiple settings, multiple ICUs, and for example, for ventilator bundles of infections and preventing infections, sepsis bundles. This really has energized the care that is being provided, because in the morning, even before the provider is there, we can look at how the patient is doing on the ventilator. Is he ready to be coming off for trial, for weaning and all of those things? So that has really enhanced and energized the protocol-driven care that can be standardized across settings.
Right. Rightly said, sir. I think the monitoring of physiological signs and audio video aids, these are helping you to make the real-time clinical decisions. Definitely, it helps you to standardize the practices as well. So let's talk from patient's perspective. What meaningful benefits has telecritical care delivered in terms of safety, outcomes, and continuity of care? Maybe you can tell us some real-world examples.
Yeah, it has, outcomes, as I told you, patient safety is a great example. Outcomes are really very well known in the ICU setting, and not only ICU setting, and beyond ICU setting. Good ICU care allows better care, a shorter length of stay, not only in the ICU, but in the hospital in general. Not a good ICU care augmented by tele-ICU allows for lower mortality, not in the ICU, but also impacts overall hospital mortality. So there's a lot of data on outcomes, but patient safety is a really great example because this is continuous monitoring, and there are so many examples I can tell you, and I feel where it is life-threatening that ICU, tele-ICU has prevented those life-threatening events that it's hard to put it in a data form, but they happen every day. And that is one of the examples I would give you is patient pulling out the endotracheal tube, not having enough, having pain or not have enough sedation. And then sick patients, what they do, pull out their endotracheal tube. And if it is not attended to immediately, it can result in really serious adverse outcomes. And because we are continuously monitoring trends in the ICU, it allows us to get those alerts and then alert the bedside team to come to the patient's bedside and take necessary intubation. So that I think are a good example for patient safety. There are also patients who are attempting to get out of the bed or preventing falls. There are so many examples that happen day to day. But one of the biggest benefits I feel, and if I may say so, is that it is a reassurance for not only the patients, but their caregivers, their families at the bedside, because many times in the ICUs, you have patients who are sedated and you are not communicating with the patients per se. Most of the time, you're actually communicating, making decisions together with the families. And when there is not a physician is not available at the bedside or a critical care trained physician is not available at the bedside, it's actually really reassuring to go on camera, talk to the patient's family, make them understand what is happening. And sometimes actually, if real complex decisions have to be taken, then we can facilitate those kind of discussions. We can make them understand what's happening with their loved ones. And I think that is a real good example where we can make a difference by reassuring and providing information, and for them to know that a trained critical care trained physicians, nurses are available. And even if there's no one at the bedside, it doesn't mean that we are not taking care of the patient, because we are behind the camera, we are monitoring, we are continuously providing support.
I think you've given a very valid example. When the patients are sedated, they themselves don't know what they're doing. So, what specific advantage do telecritical care tools offer to, say, remote or resource-limited settings compared to traditional ICU models?
That's a great question that you have asked me, and that's the question that is, that's one of the reasons I'm currently the chief telehealth officer at University of Mississippi. But prior to that, I was in a very urban setting in New York, where I established and ran a large ICU at a largest health system in New York, and helped set it up and ran it for many years. But at some point, and at one point in my career, I wanted to move to expand this reach in smaller, resource-limited areas. And the most hospitals here don't have the ability to provide tele-ICU care as it has been established. And the question was, are we creating disparities within how care is being provided between different hospitals, one that have great resources, the others are lacking those resources, and how can we make that equitable? And that was what brought me to University of Mississippi Medical Center. Mississippi has a large underserved population. There's shortage of providers, shortage of critical care physicians here. And during the pandemic, we saw that there were sick patients that they were taken care of smaller hospitals that lacked the resources. So it was what drew me here to come and say, how can we allow smaller resource limited hospitals to provide care almost at the same level as larger health system? How can we bridge that gap? And it has been challenging. It has been challenging, as you said, because the resources sometimes it is a tele-ICU is not a cheap endeavor. I mean, there's a lot of that goes into from having good IT support, good infrastructure, good EMRs. So how do we do that? How do we and it's an expensive endeavor, so not everybody can afford that. So how can we bridge that gap when it is such a there's certain cost that is attached to bringing a full comprehensive package. But what we have done, we have found in the last several years that I've been working here with rural hospitals, smaller hospitals, and we can take some of those elements that is a complex, comprehensive package and still apply to smaller hospitals, because at the end of the day, what they're looking at is that how to keep patients in their communities. In the smaller communities, patients don't want to go to 50 miles away. It's a burden to them, to their families. And then if you look at financial viability for these smaller hospitals, how can we keep these hospitals from sending patients away when they can keep them, and preventing those unnecessary transfers to large tertiary centers? So that has been always an issue. So what we did, we said, okay, let's take some of the elements that these resource limited hospitals can still work with. And for that is the audio video technology allowing an intensivist, critical care physician to come and evaluate the patients in the ED and the med surg floors and the ICU has been proven to be the most beneficial. And so we have cut down some of the other elements, and we are focusing on providing support. And we have seen that even that allows them to take care of sicker patients and prevent unnecessary transfers. But it is something that we are continuously working to improve, and the technology is moving. It is becoming cheaper. AI is coming, and so hopefully in the next few years we will be able to bridge that gap where equitable care is provided by high resource settings as well as low resource settings to the same extent.
Yeah, I think technology is helping us to do that and bridge the gap. And this is how we can make the care equitable and accessible to all. So my last question to you would be, beyond remote care, how are tertiary care centers using telecritical care today? And where do you see its greatest future value?
So the care has tele-ICU established a paradigm that has over time been adopted by other specialties as well. But what health systems have realized that you can take the expertise and provide that expertise outside the ICU setting. So I would say they started with, okay, what can we do outside the ICU setting? And I always tell my team is that a sick patient is a sick patient. A critically ill patient is a critically ill patient, whether they're in the ICU or the floor or the ED or the home. And we can provide support, not in the ICU. We are trained to provide support to critically ill patients, not critically ill patients just in the ICU. So, for example, if there's a rapid response happening on the floor, it's not always feasible for the intensivist to run and leave things in the ICU and run to the surge floor to support the rapid response team if something is happening. But if they can bring the camera there, then we can be there and support the team at the bedside to evaluate the patients, triage the patients, whether the patient can be taken care of on the floor or do they need to go to the ICU. That's one way to do it. The other way, the other way we can actually enhance is the throughput efficiency in the hospital, because in many busy academic medical centers which are running at high occupancy, they have always have critically ill patients boarding in the ED because they are not able to find beds. They are all rooms are full, but you can't send the patient somewhere else. So they are boarding. Sometimes they are boarding even in the hallways. So and what happens then, and even with the best of effort, there always, things fall through the crack, leading to a little bit of worse outcomes. Data has shown when the patients are boarding in the ED for longer duration. So what ICU can do it is, tele-ICU, the nurses can provide support to those patients who are boarding in different locations, whether in the ED or PACU or other areas of the hospitals. Then we can take it even further. And some academic medical centers said, okay, well, you can then manage the flow throughout the hospital. If anywhere there is a need for an evaluation where the patient needs a ICU level of care, then you should be there triaging, evaluating the patient, and managing which patients goes to which ICU, and keeping a track of how patient flow happens in the entire hospital. Well, then they said, okay, then now you have achieved that. You are doing it in the hospital. Why don't you do it at the across board? Meaning, start fielding calls from outside hospitals for transfers, accepting transfers. So having a ICU physician who's working at the bedside, having them, take their time away from what they're doing, and then getting involved in evaluating transfers, which can be sometimes a time-consuming process. Busy academic centers have said, okay, tele-ICU, you are there. You can start fielding calls from outside hospitals requesting transfers, because now you have an idea about our capacity, our occupancy, and then evaluate. And the whole idea is that allow sicker patients to be accepted and less sicker patients to be taken at the local level. So you are getting the right kind of patients who really need academic center level of care. Because, and I can tell you, there was a fascinating data that I saw in our own previous health system, that many patients who were coming to the academic medical centers, they were discharged either the same day or the next day, which basically was pointing out to the fact that the triage was not done appropriately because these patients were being sent back. So tele-ICU started helping, and many academic centers have started initiating those processes where they are involved in evaluating patients for transfers. Now, another thing that I find is really fascinating, where tele-ICU can really provide value. So in the U.S., there is a shortage of providers, a shortage of especially nurses. And then what happens is that many nurses who are coming and taking and working in the ICUs are straight out of school or don't have enough experience and the confidence of taking care of critically ill patients. So having an experienced virtual nurse that is available round the clock enhances their competencies, enhances their confidence. And the same is true for residents and fellows. It allows them to come and then allows them to see a variety of critically ill patients just by sitting next to the intensivist in a hub. So the education piece is really developing as a very fascinating, way of utilizing tele-ICU. So to answer the question, we are moving in many, many different directions. And I think where I see where the future is going, what I call is integrated multimodal delivery of care, where bedside is still the anchor, but the ICU is now receiving so many information that enhance coming from predictive analysis and clinical decision support that the bedside team is the anchor, but then there are remote patient monitoring, there is wearable devices, all integrated in dashboard, and for a remote provider to evaluate and then support the bedside team in taking better care. So more integration in the bedside with the bedside team, and actually offloading them in a way to so that they have a better work-life balance, reduce provider and nurses burnout. That is where I think the field will be going, and of course enhancing patient care, and maybe at some given point of time, virtual care is moving to the virtual care at home, and ICU team would be more involved in providing some care at home together with the tools that they have at their disposal, but also working with EMS then when they are going at the patient's home, evaluating the patient, saying yes, stabilize the patient at the point of care, and overall the goal would be to improve outcomes and enhance work-life balance for the providers.
I think it's very well said, sir. I think we can take so many key takeaways. We have understood that how it can be beneficial in future, not only to increase the competency of one who is at the bedside, but for triaging the patients in the ED and other floors as well. So I think technology is the way, and tele-ICU is the future. Thank you so much for joining us
Thank
today.
you, Dr. Khurana. Thank you for the invitation. It's been a pleasure.